For so long, the voice of those who are treated has been ignored. It hasn't been listened to, and they've been seen as unreliable witnesses to their own life. You know, it's the only area of medicine I know where you ignore what the patient has experienced.
Welcome to this lecture in our series about new directions in psychiatry. This lecture is a special occasion, and we have Robert Whitaker here, and this is in collaboration with the Danish Voice Hearing Network, and Olga Rönigman will introduce us to our speaker.
Yes, hello. I'd like to also welcome Robert Whitaker from the States on behalf of the Hearing Voices Network, of which I'm very proud to have been able to bring him over here. His book, Mad in America, changed my life. When I came out of psychiatry, I knew there was something fundamentally wrong, but I didn't know what. And I read that book, and then I read it again, and I looked at all the references, and as I say, I got off the psychiatric motorway. I found an exit sign, and I found a whole world out there. His newest book, Anatomy of an Epidemic, is going to change psychiatry. So without further ado, I'd like to welcome Robert Whitaker to Denmark. This is the first time he is here, and won't be the last. Thank you.
I've been traveling a lot in the last couple of years, but it's the first time ever in Denmark, so thank you. So by background, I'm a journalist. I've been writing about medicine and science for 25 years. I was a newspaper reporter for a long time, covering medicine. For a while, I was the director of publications at Harvard Medical School, a very traditional position. And then I also had my own publishing company for a while that focused on the development of new drugs. I had no particular interest in psychiatry. The way I got into this was in 1998. I was co-writing a series for the Boston Globe on abuses of patients in psychiatric research settings. Now, one of the things we did in that series is we wrote about studies in which they had withdrawn people diagnosed with schizophrenia from their antipsychotics, and we said that was an unethical thing to do, because you would never withdraw a diabetic from insulin, so why would you withdraw someone from schizophrenia from a drug that's like insulin for diabetes? What happened though for me when I was doing that series, I came upon some studies by the World Health Organization that challenged that belief system, or what I knew to be true. And the World Health Organization had twice conducted studies that compared outcomes in 3 poor countries, India, Colombia, and Nigeria, with outcomes in the US and 6 other, quote, developed countries. And actually, I think Denmark was one of the developed countries in that study. One was a 5-year study, and the other was a 2-year study. And each time, they found that outcomes were much, much better in the developing countries of the world. Much better, in fact, in India and Nigeria than in the US and other developed countries. And the World Health Organization concluded that living in a developed country is, quote, a strong predictor you won't do well long term if you're diagnosed with schizophrenia. So I wanted to know why would living in a rich country with our advanced medicine and all the social care we can provide people, why would that be a predictor you do poorly long term? Now if you look at those WHO studies, you'll find this. The first one was a 5-year study, and after they were very surprised by their outcomes, and they hypothesized maybe the reason for the better outcomes in the poor countries, in the developing countries, is that the patients were more medication compliant. They took their antipsychotics more regularly. In the second study, they measured medication usage, and they found this. In the poor countries, whereas they used the medications acutely, over the short term, they only maintained a very small percentage of patients on the drugs long term. Only 16% of their patients did they maintain them on long term. Whereas, of course, continual drug use is the standard of care in the US and other rich countries. I understood the medications to be absolutely essential, and yet in this cross-cultural study, the better outcomes were in countries where they used the medications differently, and only a small minority were kept on the drugs long term. Anatomy of an Epidemic was to really look at that question, is how this drug-based paradigm of care is working for us as a society in a larger way. And the common history is this. In 1955, we get a drug called chlorpromazine, and it arrives in asylum medicine in 1955 And this kicks off a psychopharmacological revolution, this great leap forward in care. And this drug is remembered today as the first antipsychotic. Do you hear that language? Antipsychotic, as if it's an antidote specific to psychosis. Like an antibacterial, like penicillin is an antibacterial drug, an antibiotic. It's that same sort of phrase. And then in 1998, the U.S. Surgeon General in the United States, who's the top doctor in our country, wrote a report on mental health, and he says this: prior to the arrival of Thorazine, we lacked treatments that would prevent people from becoming chronically ill. And then as part of this story of progress, beginning in 1987, we get Prozac on the market. Now this is the first of the second generation antidepressants, said to be better than the first generation. And then we get the atypical antipsychotics, drugs like Zyprexa, Risperdal. They have these names in Denmark.
Yes.
Yeah.
And these drugs are said to be better than the old standard antipsychotics. So this is a story of medical progress, of a psychopharmacological revolution, and the drugs getting better, and they fix chemical imbalances in the brain. So what I did as a first step of putting this story of progress under a microscope is just look at the number of people in the United States in need of government care. In other words, they were unable to live by themselves, and this is sort of known as the disabled mentally ill in research terms. So in 1955, there were 360,000 people with a psychiatric diagnosis in mental hospitals at the time. You look at the population, and that's a disability rate of about 213 people per 100,000. This is the moment Thorazine arrives in asylum medicine. Now in the United States, between this time and this time, we deinstitutionalize. We basically empty our state hospitals, and we set up systems of care in the community, basically shelters, and we also set up a Social Security disability program. So someone in the community gets a payment and that enables them to live in the community. And what other researchers have said is if you want to track the disabled mentally ill in our society, you now have to look at people on that Social Security disability program due to mental illness. And you find that the number between 1955 and 1987 of the disabled mentally ill grows from 360,000 to 1.25 million adults. That's this era of the first generation drugs. In 1987, the United States spends about $800 million on psychiatric drugs. In 2007, we spent $40 billion. So a 50-fold increase in spending. So you see in the United States, during this modern era, an increase in disability. That's just the numbers. Now, since this book came out, I've been asked to speak in a number of other countries, and as I go to the other countries, I try to look at their disability numbers during this modern era. Here's your data. This is new cases. So you're looking at about 3,000. Now you're up at 9,000. That's a tripling over this last 10 years alone. By the way, you have about 5 million people, is that correct?
Mm-hmm.
Your rate of disability now, new cases, is much higher than ours is in the United States. This would be like 600,000 in the United States by population, because we have about 300 million. And we're getting about 100,000 new cases. So your disability rate is really high. Now, here's just a chapter that's just looking at all the new cases of disability and what percentage are due to mental illness. You'll see you've increased from about 25% to about 50% over the past decade. Now, the disability data doesn't prove anything about the merits of the drugs, necessarily one way or the other. But you can see it raises a question for us as a society, right? As we embrace this paradigm of care, embrace the diagnostics in the Diagnostic and Statistical Manual put together basically by the APA, is that a belief and a paradigm and a use of the drugs that is reducing the burden of mental illness in our societies? And what you see, it's going the opposite in society after society. The other thing that's interesting is what's really driving the increase is people with depression and bipolar illness. It's actually not the psychotic disorders, it's the affective disorders. This is just a question I think we all need to answer. I believe here in Denmark, aren't you making it harder to get disability as well?
From next year, yes.
Next year?
Yes.
The U.S. is really making it hard to get disability because we can't afford all the people going on disability. So you can see societies basically have to figure out a paradigm of care that doesn't keep on increasing the disability numbers. And so we're going to have to figure out what's going on. Now, having raised that question, you can see the disability numbers do raise an honest, valid question, and that is this. How do medications shape the long-term course of people's lives? And in terms of their ability to work, their ability to function, their physical health, etc. Now, one of the reasons I think Anatomy of an Epidemic is getting some attention, both in the United States and elsewhere, it's really the first book, even in the United States, to look at the question of how the drugs affect long-term outcomes. Because the reason the drugs get approved by the FDA and basically in other countries is they're shown in clinical trials to knock down the target symptom of a disorder better than placebo over the short term, right? And that is seen as effectiveness. But what is happening to people's lives over the long term is a very different question. And really what I try to do here is look at what science is telling us about how the medications shape lives over the long term. And that's really what's new here. And now the reason I want to do antipsychotic drugs is this tonight. First of all, antipsychotics are seen as at the heart of that psychopharmacological revolution, right? They're the drugs that made it possible to empty the hospitals. Second, they're the best studied class of drugs over the long term, over the past 50 years. And third is this. If there's any class of drugs that should show a clear benefit, it's the antipsychotics. Because we as a society believe if you have a diagnosis of schizophrenia or a diagnosis of a psychotic disorder, you need to be on this drug for life, right? That's the common wisdom. And so if that's so, if we believe in that so fervently, the data here should be really solid, showing that the drugs improve the long-term course of schizophrenia. Now imagine you're a researcher in the 1960s. You put people on these antipsychotics. What's your next question? How long should the patient stay on the drugs, right? And what they did is they ran studies designed like this. They took the good responders to antipsychotics, those are the ones where the psychotic symptoms had abated, and then they ran studies where they abruptly withdrew half from the drugs, the other half they maintained on the drugs, and those abruptly withdrawn from the drug relapsed at a higher rate, meaning the psychotic symptoms came back and they had to be rehospitalized at a greater rate. So researchers said, aha, you remove the drug, the disease comes back. Staying on the drug lowers the risk of relapse. You see the reasoning there? Okay, and that is the rationale for long-term use. It's relapse studies, where you abruptly withdraw the drug from half, they relapse at a greater rate. Now, I think there's actually one more part of the evidence base, and it's the doctor's perception. Imagine you're a psychiatrist working in an emergency room. People come in with psychotic symptoms. You give them an antipsychotic. The symptoms abate somewhat over the next 6 weeks. So what do you see? You see that the drug works. Then the person goes home, says, I hate these drugs, goes off, gets rehospitalized, comes back to the hospital. What does the doctor see? Got to stay on that drug. All right, what's missing from the evidence base? Well, there's a couple things missing. Imagine we ran a study like this. We have people come into an emergency room. Half are put on psychosocial care and are not put on drug, and we're going to follow them for 3 years. The other half are put on drug, we follow them for 3 years. In other words, this is a never exposed group. And we start looking at something more than symptoms. We look at employment. We look at cognitive function. We look at physical health. Do the relapse studies tell us what might happen to people if they weren't put on the drugs? They don't, right? The relapse studies tell you once you're on the drug, don't come off them abruptly. But they don't tell you what might be happening if you treated people with psychosocial care but didn't put them on drugs. The second thing is the relapse studies may have a design flaw. It's the abrupt withdrawal. It's now well known once you're on an antipsychotic, if you abruptly withdraw that drug, it increases the risk of the relapse. But then a person named Ross Baldessarini, he's a famous psychopharmacologist from Harvard University, been doing this for a long time, said, but wait a minute. What sort of relapse rate would we get if we get a gradual withdrawal, try to take the drug away slowly? Now, there were very few studies in the literature where they had tried gradual withdrawal, but he managed to find a few, and in those studies he found that the relapse rate was only 1/3 as great as it was in the abrupt withdrawal.